put in. It is on the catheter itself. Okay, so this is a 14 French 5 to 10 ml balloon, and I know I put in 8 mLs, and I would document that. And then I would give my patient some instructions. We've put the catheter into your bladder. It will be a little bit irritating for your urethra. It may actually provide you the sensation that you actually need to pass urine. It's okay. Please relax that musculature because there is a catheter in place and it will collect all that urine. So even though you have the feeling or that urgency to go, we have something in place to take care of that. So please don't worry about that. Now if you are having any discomfort, please call me. I'll be in frequently to check your output and empty your bag. When you need to get out of bed, please call me because I don't want you to trip on this catheter. Okay? Call lights within reach. Make sure that there are no other questions, and then I can go. Okay? One more thing with your bag. As it's draining, as you approach 800 cc's, you need to clamp off the bag because you can throw somebody into shock if you allow too much urine to come out at one time. We'll learn more about that when we get to the pathophysiology of the disease process of the genitourinary system. But I want you to know right now that 800 in the bag and you have to clamp it off. And by clamping it off, I only mean that you have to hold it in your hand for 15 minutes and then let it continue to drain. And we do that between 8 and 900 mLs. So if we've got a lot in that bladder and a lot is coming out, then we just stand here and wait until it slows down or stops. And if we get to 800, then we clamp it, wait 15 minutes, and then let it continue to drain. All right. And like I said, you will understand more about that particular process when we get through the pathophysiology of catheters. Okay? Any questions for?
I do, I'm sorry. To secure the catheter,
Yes.
we want to secure it in the hard, clear plastic tube instead of the yellow to allow more movement for the
The
patient.
place that we are going to put our
Stretchy band.
tape
Yeah.
on this is at the Y connection.
Okay.
Okay, because if we allow a piece of tape to go like this,
Yes.
it gets
I was
stuck.
saying more on.
No, we don't.
Okay.
We want it at the Y connection.
Okay.
Now, when we have the fancy clips that come in
That,
the
like,
hospital
Garter
sets,
belt thing?
those are for leg bags for men that have catheters, or for females that have catheters that they're going to be going home with. It's a piece of pre-made tape with a hard plastic Vit clip
Oh, yes.
attached to it, and
Clip
that's
it.
what we'll be using in the facilities more than likely.
Okay.
All right, but if we are relegated to just using tape, we need to make sure that we have a piece of tape at the leg and then a piece of tape over this area so that this Y is getting stuck,
Okay.
okay?
Thank you.
Because we certainly don't want it to pull out. That
Mhm.
causes quite a bit of trauma for the urethra.
Especially with the balloon inside. Ooh.
Yes, it'll stretch all that anatomy out. And you'll have to put a catheter that's larger in to actually block the passage of urine from leaking around it, yes.
Will the doctor tell you what size to use, like 14
No.
or 16 French?
Not unless, that's a nursing judgment question, unless there's problems with the prostate or it is a child. Somebody that has another disease process or different patho or different anatomy that would require you to use a different size. We like to start out with a very small size because it's less trauma. But if you have a gentleman that's had a number of catheterizations in the past, you may be starting with a 20 French rather than a 14 French.
So 14 is like the baseline to start with
16
that.
is the most common that they carry in the hospitals and the kits. 14 French is what fits into our mannequins.
Okay.
8 French is what we put into children. Okay? Yes.
How do you determine how much water to put into the balloon? You said between 5 and 10. Right?
That's the recommendation by the manufacturer. I suggest that you blow it up all the way because it's less apt to fall out with trauma. Okay? It's more likely to be secure in there, the more fluid that you put in. The reason that I could not inflate it my full 10 cc syringe is, I don't know if you noticed this, but at the Y connection, this part of my port started to swell up with fluid, which is also what caused when I broke it apart for it to spray. That means that I had not passed the 14 French all the way into what this mannequin's urethra is. Okay, so it hadn't made it all the way into the bag that is my mannequin's bladder. So it's much easier on a person because a person is very elastic, and there's not a lot of strictures unless it's a man that has an enlarged prostate and strictures in the penis. Okay, ladies don't usually have strictures anywhere.
Quick question. When you say to clean to remove the iodine to reduce the chemical burn, that's right after you're pudding, or that is maintenance?
As soon as you secure to the leg and you put the catheter bag down so you're at a good safe level for the bag, then you can begin your pericare.
Okay, so again, pericare, apply the catheter.
Pericare again, and then pericare as needed,
Yes.
hourly or, whatever the hourly rate is.
Once the catheter is in,
Mhm.
your sterile fill is done, right?
Yes, yes. So you see at that point, I tried to keep my dirty hand spreading the labia for as long as possible, and then once I had pushed it and I had seen the urine, pushed it another inch to 2 inches, then I held it right where it was, and this hand came off of the labia. Well, it's contaminated. My contaminated hand did fill up my balloon by depressing my syringe of sterile water into the balloon. And that's okay. At that point where you are done advancing the catheter, sterile technique is now over. All right?
I have a quick question.
Mm-hmm.
Just for my understanding, does the iodine that's used to clean, does that affect the sterilability of the urine? Like if you're doing a urine collection right after it, does that affect that urine?
No. If you've done a good job cleaning the area, a very good job around that urethra, and it is not a blind stick, which means you were able to see the urethra the whole time and you passed the catheter straight through the urethra, there's no problem. Then you get your sample of urine from this port right here. Okay? In the hospital, a lot of them are Lurlock. If you are going to get a sample and the person has had the catheter in for several hours, and it's not, you just put it in and you're getting your specimen out, you need to clamp the tubing for whatever the protocol is at the facility, and then draw urine straight from the bladder is what our hopes are, because if you allow this to be straight and draw out of this, you may get old tube urine. We want fresh urine from the bladder. So we need to make sure that we're clamping this off before we pull any sample. And it's okay to, as soon as your person has enough modesty and the catheter is secured and you've done your pericare, to go ahead and take a sample right away. You don't need to clamp at that point. You just need to go ahead and get your sample.
Now, the first one, I remember Ms. Stindle had said that we can collect it from the bag.
First sample can be collected from the bag unless otherwise noted in the order.
Okay.
But that's with a brand new Foley placement. So if you can't get it out of that port, or you don't want to because you just covered them up and they look just so comfortable, that whole everything is sterile because you just put it in. So the inside of everything is still sterile. And the microbes that are in the urine have not had enough time to still continue to grow inside that bag. So this is just like a fresh urine out of the bladder. So you can collect your first sample from the bag if you were the one that put the Foley in.
Okay, and just to clarify, the cleaning, it's in the middle?
Last is in the middle.
Last is in the middle. And
First
that's
is
where I'm
far
looking for
away
the
from
weight.
you.
Far away, okay.
Second is close to you, always from the top to the bottom. Mom taught us how to wipe ourselves. It was from front to back, right? And then the last one is straight down the middle, and that is the one that you are really looking for your anatomy. Try to identify your anatomy before you clean anything, because you probably want to get right around that anatomy with each swipe. It's that last one right down the middle that really counts, that you have to be sure that that iodine got on that urethra and in the crevices of the urethra. Okay? Any more questions?
That blue alligator clamp thing? that
Yes.
You had your thing, you had yours.
Yes.
What?
What's
you-
the function of this?
Yeah, other than holding your stuff.
Clipping it to the bedside so that your catheter can maintain a long straight line and doesn't get kinked anywhere.
That's good.
All right, because this thing is not strong enough to
Clamp.
clamp anything off. All right, so this is strictly for clipping to somebody's gown if they're going to be walking, clipping to the bed to keep the catheter in a nice straight line. Okay, that's all that's for.
That's awesome.
All right, anything else?
And they can sit up right away afterwards if
Absolutely.
they want to?
You can make them as comfortable as they.
Okay,
Yeah.
so there's no positional thing?
No, the only position is, what position did I have this mannequin in for insertion of the Foley?
Lithotomy.
Lithotomy.
Oh,
Low lithotomy, okay? High lithotomy, remember, is up in candy cane stirrups or other stirrups. Low lithotomy is just legs on bed, right? You can, with some persons, if they cannot maintain the knees up for you, but that their hips don't have any problems, you can put them in frog-legged, like that. All right? But you really have to assess that they don't have hip problems before you do this. A lot of people that our patients that we'll be doing in the ER together is for a possible hip fracture. They always get a Foley. So it might be that one leg can be up and the other one we have to just maintain straight, maybe even straight out like this.
How difficult does that make the procedure?
Very difficult.
Especially on old people.
Very difficult. But there are some tricks that we can do, stuff like this.
Scream out of this bed.
Well, okay, so what you would do with this bed is you would Trendelenburg it, so the head was down, and the weight of their pannus and their anatomy was north, and hopefully that would shift some of everything, the anatomy, in a way that you would be able to visualize it, because you're not going to be able to pull the anatomy to the sides anymore, it's just going to be one side and up.
Now, if you have somebody that has a large apron, you would get an assistant, somebody to come in and help you.
Yes, it's always good to have an extra set of hands, but then again, otherwise, Trendelenburg the bed, and a lot of their pannus will come up, and it should be out of your way a little bit. Your pen lights are going to be mandatory when I come in with you, because I'm going to put your pen light in my mouth with gauze, and I'm going to hold it while we get in there and do it the first time. The second time that you do it, I'm going to try not to touch anything. Okay, but the first time, I'm going to be in there helping you spread the anatomy, helping you visualize everything that you need to see and do, so that you can get one successful one under your belt really quick, and then the next time, I'll be backing off. And I'll still be there, like your safety net, but I'm not going to get my hands dirty, unless it's really difficult anatomy and I need to get in there for the patient's benefit. Okay. Any more questions? No? All right, great.